Welcome to Healing Together. I'm Nicholas Boileau. Today I'm speaking with Dr. David Hass and Carrie Armour. Dave and Carrie are deeply involved in the world of medical cannabis, but come to it from very different perspectives. Dave is a medical doctor who understands the science and has seen firsthand what medical cannabis can do for some patients. Carrie is an attorney who has devoted her professional life to working on medical cannabis policy and regulations. And it's a really complicated landscape, both legal and medical. Our conversation helps put context around why it's been so hard for many people, both doctors and patients, to get a straight story on medical cannabis, and how a very mixed bag of regulations makes it even hard to conduct good scientific research. Dave and Carrie even talk about the commercial explosion of adult-use recreational cannabis and CBD, which seems to only add more confusion to this complicated landscape. I learned so much from Dave and Carrie, and our conversation made me want to learn even more. I hope you get as much out of it as I did. I think it'd be good to start with just a brief introduction from each of you about what brings you to this conversation, your professional background, anything else that's relevant to the topic we're addressing.
Great. Well, thank you, Nicholas, for having me today. I'm really excited for this conversation. My background's kind of interesting. It really kind of mirrors medical cannabis policy. I'm an attorney. I started my career at the prosecutor's office here in Chicago, where we criminalized cannabis possession and we prosecuted it all the time. That's how I started my career. I pivoted to healthcare. I spent about a dozen years at the American Medical Association, where I worked in their state government affairs shop, where we created advocacy campaigns for state medical associations and national medical specialties. And I covered their public health initiatives. And it was there that I really started to pique my interest about medical cannabis programs. Because what I found is as the states were really starting to look at medical cannabis programs and legislation was, really percolating, organized medicine really didn't know what to do with these programs and really wanted nothing to do with them. So these programs were being enacted, and unfortunately, physicians were not at the table to understand what they were. They had a lack of education. There was really no interest there to create educational opportunities. And eventually, about 5 years ago, I left. I started my own advocacy firm, and the bulk of my work revolves around cannabis education. I've been really fortunate to be part of the Medical Cannabis Research Alliance, which you see above my shoulder, and we'll get into that later. So I'm really looking forward to this conversation today.
Great. And Dave?
Yes, Nicholas, thank you. I'm David Hass. I'm a clinical gastroenterologist, physician in New Haven, Connecticut. My journey to how we ended up on this podcast really stems from the fact that I've always had a very strong interest in complementary and alternative therapies in the treatment of gastrointestinal diseases. I do a lot of work with patients who have not only functional bowel disease, and that includes patients where they have significant pain, significant discomfort, but they can't find something that has been helpful for them from traditional allopathically trained methodology. And then I also do a lot of work with end-stage pancreatic cancer patients who suffer from quite a bit of discomfort and equally are struggling and looking for some sort of relief. About 10 years ago, I decided that in addition to my traditional training as a medical gastroenterologist, I wanted to explore alternative and complementary therapies as a means by which to offer my patients a combination of different modalities. And I became a licensed hypnotherapist for functional abdominal pain. And that led me down the road of really learning about research-driven complementary therapies. And as a result of that, I've been a strong advocate for research in the space of complementary therapies, inclusive of medical cannabis. And therefore, given my healthcare background and also my interest in exploring those sorts of opportunities for patients and advocating for patients, I was asked to be on the Alliance, and I'm really a privilege to do so.
Great. Well, that's a great introduction and a great way to launch into what the Alliance is. I think before we move into the conversation, it's important to note that it precedes the MCRAA annual conference. Can you just give us an overview of the conference and its purpose.
So, the Medical Cannabis Research and Advocacy Alliance was created last year, and it is a physician led, patient focused organization that really has come together to advocate to remove the barriers to medical cannabis research. And so it's a group of state medical associations, national medical specialties, patient groups, and industry. And so we are having our first conference in March. It's a virtual event, like most things this past year. And it's a half a day event where we're really trying to demystify medical cannabis. So we're going to be exploring the endocannabinoid system, quality and potency concerns. We are going to talk about policy and implications for healthcare providers. And most importantly, we're ending our day discussing what the current state of research is and again, the barriers to that research. And again, I forgot the best important thing is we are going to have a keynote. Hopefully we get someone from the Biden administration. We're really excited about this is because we really think that this is going to really open the doors for understanding medical cannabis.
And this is strictly about medical cannabis, right? Not recreational cannabis?
Yes, thank you for bringing that up. That's a really important. This is a group focused on medical cannabis.
Specific to the Alliance, how are most doctors and patients getting their information now?
There is really a paucity of information for most healthcare professionals that are out there. And in fact, what I have found is that many healthcare professionals, specifically physicians who may not be as knowledgeable about complementary therapies, they really shy away for even embracing this as a concept, medical cannabis, partly because of their concerns about any sort of responsibility or liability that they may incur professionally, but also because of a lack of understanding of the endocannabinoid system or how it could really benefit their patients. Now, interestingly, there's a wide range of research in neurologic literature. There's burgeoning literature in my field, which is gastroenterology, and also in pancreatology. But a lot of that literature is hampered, and a lot of the research is hampered by access to good research trials. And so it's a combination of physicians not being well informed and also research not being incredibly robust yet. And that's really the purpose of the Alliance and the conference, to introduce concepts to healthcare providers, advocates, even patients, and maybe even government officials to understand the importance of getting that information out there so that we can help patients, physicians, and really the healthcare system in general.
Is some of the information on medical cannabis getting subsumed by this sort of overwhelming wave of information on recreational cannabis as it spreads through the states?
Absolutely. Absolutely. I mean, it's really interesting that, we've got 36 states that have medical cannabis programs. We've now have 15 states that have adult use programs, meaning recreational. And, it's very difficult for physicians and healthcare providers to know where to go for reliable, trusted, unbiased information because, I feel like the green wave has been unleashed across this country. And again, this conference is really to kind of level set what the facts are about medical cannabis. And again, to really advocate to increase medical cannabis research and remove those barriers.
So you've given a great reason, almost a reason for being, for a definitive place to get information and share information on medical cannabis. Does it make sense for patients and consumers to attend this conference, or is it just for professionals working with cannabis?
Well, I think our focus initially is for anyone that has a distinct interest if they'd like to attend, but we're going to be focusing on the research, the physiology, the legislative actions, and basically creating infrastructure so that people can get information that is reliable and information that they're comfortable with. I want to actually just add one point to the comment that Carrie made. As a physician, I will tell you that most patients, if you don't ask them, they're not going to share with you because they're going to be a little reluctant unless they see that you're an interested party in embracing types of therapies that may not be traditional. But the data, at least in my field, is that at least 50% of patients are or have or are using medical cannabis. The other 50% have thought about it. So I think it's really robust time for us to address this, because if we don't start addressing it in a systematic way, patients are going to start doing things, and they already have, where we may not know about it. And that can have significant implications for prescriptions of traditionally prescribed medications and what have you.
Can you talk a little bit about how we got here, the history that gets us to a place where something is has such breadth in our culture and society, and yet there's a need for a galvanizing of the information and for more understanding between different parties?
This has been a patient-led, advocacy initiatives across the country to create medical cannabis programs. And physicians have been very reluctant. I think it goes to the schedule, the fact that it's a Schedule I substance. So what that means is that cannabis is put on the first schedule of the Controlled Substance Act, which defines it as having no medical benefit and a high risk for abuse. Dave can maybe correct me if I'm wrong, but so what's included with cannabis on that Schedule I is heroin, meth, ecstasy. What's on Schedule II is, opioids. I mean, it's crazy that cannabis is on Schedule I. So what this does is it creates this big schism between what's legal at the state level and what's illegal at the federal level. And so physicians are very reluctant to consider cannabis because of their DEA license, their lack of they had no education in medical school on what the endocannabinoid system is. And once patients get a recommendation to purchase cannabis, they go into a dispensary and have zero medical assistance with purchasing, making these purchasing decisions in the dispensary. And so that is a significant concern to the physician community. And I'm sure Dave can talk to that.
So, Nicholas, there's a wide variability in the way that medical cannabis is dispensed. In Connecticut, for instance, which is one of the strictest states, a licensed pharmacist must be the one to dispense it. And that's actually, in my opinion, really sound medical judgment. These are people that are understanding of pharmacology. They understand the way that the medication or the active substance interacts with the body. And most of, not all, the dispensaries within the state of Connecticut are owned and operated by licensed pharmacists. These are individuals that could work at CVS or Walgreens or what have you. But if you go to some other states, maybe some of the early adopters like Colorado or what have you, and I've been to dispensaries in a variety of different states, the experience is vastly different. And typically what you'll find in some of the other states where there are medical use, maybe not necessarily focusing on adult use, not necessarily focusing on medical use, is we term them bud tenders. Sometimes these are young adults that are very knowledgeable about cannabis, extraordinarily knowledgeable about the strains of different cannabinoids and what have you, but they're not trained really in the physiology or the patient interaction component. And so therefore, patients are getting a lot of medical advice from people that aren't medically trained. And that's where we really need to make sure we're standardizing a process for safe distribution.
Yeah. I would say of the 36 states, there's 36 programs, and each is very unique. And unfortunately, the majority of them don't have a similar program to Connecticut, where they require a physician or pharmacist to dispense. It's really, as Dave said, just a crapshoot on who's behind the counter.
And if I'm understanding it right, all of this is operating under the umbrella of cannabis being listed as a Schedule I substance right along with heroin. So without addressing that problem, it seems like there's always going to be some fundamental disconnect in how states can operate and how they can collaborate under a federal system that doesn't even look at the therapeutic benefits of the compound, right?
Correct. And one thing I'll add, which is rather interesting as a physician, is that depending upon the legislation and the administration that's in Washington, it really dictates people's comfort level. So for instance, the Obama administration had created something called the Cole Memo, which really dictated that while it would remain a Schedule 1 substance, there wouldn't be federal resources allocated to individuals to either penalize or prosecute any physician that was abiding by state guidelines, even though it was federally a Schedule 1 substance, meaning that I could recommend that someone be given medical cannabis by certifying them through the Department of Health in the state of Connecticut. However, I wouldn't necessarily worry so much about my license or what have you at a federal level, because the administration really didn't worry so much about prosecuting responsible administration. And then we had the most former administration, which has just recently left office, that rescinded the Cole Memo under Jeff Sessions, which meant that, okay, well now as a provider, there isn't a promise at a federal level that you won't be prosecuted, even if you're abiding by state laws. And that really set people back a little bit, at least in my neck of the woods, to be comfortable recommending something that could be medicinally and therapeutically helpful solely because of the politicization of this process.
This is fascinating. And meanwhile, all of this is happening. This ping pong is going back and forth at the federal level. And meanwhile, at the consumer or patient level, there are almost like backyard studies being conducted with people using cannabis and coming up with ways to use it therapeutically. And then the medical world has to catch up and do the science around this.
That's right. And it's not easy to do. I mean, so what's even more complicated on trying to do the research and the studies on it is if a researcher wants to study medical cannabis, they have to obtain their cannabis from the University of Mississippi. They have the exclusive contract to grow cannabis in the country. They have a contract with NIDA.
Can you say who NIDA is, or what NIDA is?
Yeah, the National Institute of Drug Abuse. Do I have that right? Yeah. And what has happened is because the University of Mississippi is the only contracted university to study, or to grow cannabis, it's you talk to any researcher, it is the quality of it. There's talk about pesticides and mold in it. It's just really not conducive to really using for any quality studies out there. There's been attempts by, again, the Obama administration. They opened up a process to create more bulk manufacturers of medical cannabis to study. That was in 2016. But the DEA has not moved on processing any of those licenses. They've kind of sat there since 2016. There's been a lot of litigation to try and prompt the DEA to move forward on those additional licenses so that researchers can have better quality cannabis to study, and more importantly, to study the cannabis that patients are actually using out there.
Is this just for research, or is the university also the sole holder of the contract to produce what is able to be prescribed?
No, it's just for research. For the states license all the cultivations and manufacturers. So in each state, there are licensed cultivators that can grow and manufacture the cannabis, and then that gets sent to a dispensary, and then the patient goes to a state dispensary to purchase it. So the cannabis that is grown at the University of Mississippi is not at all, it's not used for patients.
But if you do want to do a peer-reviewed study or some sort of scientific study, you need to get it from the University of Mississippi.
Yeah, so you can, which is even crazier, you can import it, but then there's all sorts of hurdles required to do that. But yes.
How would you advise physicians who may not be familiar with the science, but know this is happening and they want to do something about it, or at least be able to discuss it with their patients? What do they do at this point?
I would say the first thing is to have an open mind. Even if you are someone who is not necessarily embracive of cannabis in general, the worst thing you can do as a clinician is with your body language and your questioning to dismiss things that patients have deemed to be either therapeutic or helpful to them, because it immediately creates a barrier for patients to be willing to share what they're doing and what they may be doing in the future. And I quoted the statistic, at least in the world of gastroenterology and hepatology, that basically 100% of patients are thinking about it, 50% have used it or are using it. And I think once physicians clear that barrier, that make it okay for patients to really share and be honest and allow patients to be vulnerable, and you as a physician to be vulnerable and say, I don't know everything about this, but I'm willing to learn and willing to listen. I think it creates, I've experienced a really much better rapport, and patients start sharing with you things about their personal lives that really are playing into some of the symptoms that they're having. And you would never know that if your body language was an eye roll, or you're folding your arms when they're talking to you, or what have you. And it's very quick for patients to pick up on that. I can't tell you the number of patients that I've seen referred to me solely because they know I have an interest in complementary therapies, not necessarily medical cannabis. But when we talk about it, they say, you're the first physician that's ever not really dismissed me or said, I don't want to know about that. It's fine. Do whatever you want to do. It's really helpful from establishing a therapeutic rapport. From an education standpoint, from a physician, I would say there is plenty of literature out there that one can read in peer-reviewed journals. However, you have to start somewhere. And I think our organization is attempting to standardize the dissemination of information, of how we actually educate not only patients, but physicians, researchers, legislators, so that the knowledge and the information can be disseminated in a responsible and standardized way.
One of the things, obviously, physicians are just as busy as everyone. I have some in my family and they seem busier than everyone. What would you advise a doctor do at this point, a medical doctor, when they're just not that familiar with the science, but they want to dig in, but they don't have the time to dig in the way you have?
We're all busy, not just physicians. I think everybody currently is busy, although we're busy in different ways now with, of course, the pandemic. We have some time now, where you can literally go onto a variety of reputable websites. And at least in the medical world, there's certainly ways to research, whether it's for the National Center for Complementary and Alternative Medicine that's validated by the NIH, or a variety of textbooks, include complementary and alternative therapy chapters within their textbooks. And most major medical centers have what are called integrative health departments in their medical centers, especially cancer institutes. And most of the major universities have a cancer institute. Pick up the phone, call the Integrative Cancer Institute, find out exactly what they're quoting, where's the research going, how they're educating patients, and how they're educating their providers. A lot of the oncologists are helpful in that regard. So I would say the standard ways that we learn about new technologies in any field, that information is out there. Through the standard mechanisms that we implement as physicians. People just have to take an interest and set aside the time to put the important on par with the necessary.
Do you think some of the medical journals that you receive as a matter of course as a physician, like JAMA, are fully addressing this, or are they a little bit nervous to delve into it?
No, there's more. I mean, I do read JAMA. I, of course, read the New England Journal of Medicine, and then I have a variety of subspecialty journals that I try to read. It stacks up on my desk until I get guilty enough about it till it spills over, and then I have to go through them. But there is plenty of interest in publishing things that might be of interest to physicians, and most importantly, interest to patients. And at least in the field of gastroenterology, there have been a variety of recent articles and abstracts that have been published, presented at national meetings just last year, at least at both of the major national meetings, one of which was held virtually. There were at least 10 different research projects that were presented on the endocannabinoid system for not only treating inflammatory bowel disease, but looking at decreased progression of liver scarring and cirrhosis, looking at the benefits of cannabis for decreasing the incidence of chronic pancreatitis. These are real problems that people are facing. And if we could have another weapon in our armamentarium to treat these real chronic conditions, gosh, it would be tremendously helpful for our patients.
So, Dave, can you talk a little bit about that, the science and how the science has played out with a patient or two?
Of course. So in my world, I would say the two fields that we see the most use are for chronic pain related to oncologic conditions like cancers, or in inflammatory bowel disease. And that's Crohn's disease and ulcerative colitis, which are what are called autoimmune conditions, where the body mistakenly starts attacking itself. And it's no different from conditions like thyroid disease or lupus or psoriasis of the skin. And what we've seen is that, as Carrie mentioned, everyone in their body has something called an endocannabinoid system. These are receptors that are located both within the immune cells of the immune system, and the immune system is what fights off infection, as well as receptors on the lining of the intestine, the lining of the pancreas, the lining of the liver. And when these receptors are activated by phytocannabinoids, and we have some actually endocannabinoids, meaning they're substances that bind to those actual receptors within our system, that's something that actually triggers these receptors to decrease inflammation and decrease scarring. And it's amazing what's been shown, although the literature isn't so robust yet in humans, but in mice and in vitro, we see a decrease in scarring, a decrease in inflammation, a decrease in illness, a decrease in hospitalization in all of those conditions.
Let's switch quickly to the policymaking side. I think states are viewing this as a great revenue generator and they're jumping on the bandwagon. Can you talk a little bit about how this is playing out and the risks?
Sure. So, what COVID really did to cannabis policy, I mean, it accelerated cannabis policy. The fact that cannabis was considered an essential business in a lot of states. Here in Illinois, it certainly was. What it did is it accelerated its acceptance. And so there is this tremendous interest in opening up cannabis to adult use, recreational use, for obviously for revenue as well. And what the risk does, and what we've seen in the states that actually have started off as a medical cannabis program and then expanded it to adult use, let's say Washington, Colorado, even here in Illinois, it really strangles the medical cannabis program. Patients have difficulty obtaining the products that they're used to. There is less of an interest in that education and that outreach to the healthcare community to educate them on what the products are. I mean, patients really do get lost when states expand to the adult use market. Again, I think that states have to be really careful before they start expanding their cannabis programs to the adult use side, and to ensure that we can have educational opportunities for healthcare providers, and most importantly, advocate to expand medical cannabis research, which is again a big problem here in the country.
Yeah, and some people are talking about cannabis addiction and whether that's possible. I know when I was young, at least certainly in the popular culture, nobody thought of cannabis as an addictive substance.
I could speak to the fact that there are some adverse effects from chronic cannabis use that we see. Mood disturbance is one. We definitely see patients who have underlying anxiety disorders sometimes be exacerbated through withdrawal symptoms. There is something called the cannabis hyperemesis syndrome that many of us who work in hospitals, myself included, see quite frequently. And we think it's through downregulation of certain receptors that control the nausea and vomiting centers in the brain. And these are patients that come in with intractable nausea and vomiting. It's rare, but I've definitely seen it. And there's, scattered reports of decreased fertility in men and what have you in the medical literature. But generally speaking, it doesn't rise to the level of addiction potential like some of the other Schedule I substances. We talk about the opioid epidemic in this country that is rampant. It's not even close. It's not even something that should be on the same page or in the same discussion. And the medicinal benefits, quite frankly, I think outweigh any untoward side effects if it's used responsibly. One other comment I'll make is that many states have instituted programs where growers and dispensaries must provide, without getting too much into the physiology, high CBD, low THC strains. And THC, which is tetrahydrocannabinol, is the component that creates that euphoria and that high, so to speak, that everyone's familiar with when they think about cannabis. But CBD, which is cannabidiol, that's actually something that's very, very helpful at a physiologic level for helping with things like inflammation and things like anti-scarring without creating some of the cerebral effects. And so states that are implementing, selling, and advocating for strains that are higher in CBD content can maximize therapeutic benefit and minimize potential downstream effects if they're concerned about altered mental status and what have you.
Dave, is CBD just one thing, or does it come in many flavors? It's sort of like, you can go to the grocery store and you can buy soy sauce, and one soy sauce is high fructose corn syrup with some flavoring, and the other soy sauce is actually from soybeans. Um, CBD is sold all over the place. You go to the gas station and there's a little thing on the counter with a whole bunch of different flavored CBDs, or at the local market. Can you just talk to that briefly?
Sure. So those are what you're referring to are the different types of phytocannabinoids. These are the chemicals that are inside of cannabis that help with either a therapeutic benefit or a phoric kind of effect. And CBD, there's only one CBD. It's cannabidiol. The difference is what you're seeing is the way that it's marketed, the way that it's produced, the way that it's impregnated into different products, whether it's a salve on your skin, or whether it's drops under the tongue, or whether it's something that you might ingest in an edible, like a cookie or a lollipop or something of that nature. But at least in a variety of different places, there are legal CBD stores, because it's really tetrahydrocannabinol that is the Schedule 1 substance that people are very concerned about. CBD is legally sold, as you just mentioned, gas stations. There's CBD only stores we see in malls all across the country. And I think a lot of people get confused because they think as though CBD is marijuana. CBD is just one phytocannabinoid, one chemical that's within the cannabis plant, and it doesn't have the mind-altering effects, so to speak, that something like THC might have.
And do you worry about the brand or where it came from, or, where you bought it, or is it all the same?
That question is really what MCRAA is really focusing on in terms of really trying to help people that are in this industry standardize a process. You certainly have to worry about anything that has potency potential or manufacturing components to it. We want to make sure that we're part of the process in creating standards so that people can have confidence in knowing that, just like when you go to the supermarket and you're purchasing fruit and produce, it's not going to have E. coli. These products are going to be made in a way that is safe and standardized with understandable potency for both physicians, other healthcare providers, and patients.
Would it make sense for us as a culture to take a step back and say, this whole area just belongs under the heading of a medical intervention, and should not be spreading itself thin across so many products and so many different types of outlets? Again, from the gas station to the pharmacy.
That's the big question. The Farm Bill. What happened with the CBD and why it just exploded is the Farm Bill, took CBD, hemp CBD, off the Controlled Substance Act. Okay, so that just opened up the market for hemp CBD, and they're still trying to figure out the regulations around it. It's been a big problem, and if they can regulate it, they can standardize. Quality measures require, good manufacturing practices like we do in any other industry. Apply that to CBD. I think it would, go very far. I think it's really tough, like they say, to put the toothpaste back in the tube. I mean, it's here, and I think it'll be very tough to claw back the CBD market. That's for sure.
So knowing that, what does this all look like in 5 years, according to you? And I'd be curious to know, even if you disagree a little bit, what each of your visions is for here's where we are in 5 years or in a decade, specific to medical cannabis and even, adult or recreational use cannabis and CBD.
Well, I'll speak to the medical side and I'll let Carrie speak to the policy and legislative side. I think if in 5 years we can have a frame shift in terms of attitude toward this and recognizing that this is something that could be of therapeutic benefit and should be in the medicine cabinet for certain conditions, if we're able to produce enough robust research to justify and validate the physiology, I'd like to see it as an alternative to some of the traditionally prescribed medications that we use for conditions like autoimmune disease, seizure activity, all of those pharmaceuticals have side effects in and of themselves. And there have been plenty of instances within medicine over the hundreds and thousands of years that we've been practicing medicine where we find antibiotics that are naturally grown. And now they're part of our standard culture, whether it's penicillin-based antibiotics or what have you. Why not take benefit from that if we can do things in a way that safely and responsibly allows for the prescription and the understanding of the science? And I'd like to see it grow to a point, no pun intended, where physicians are very, very comfortable in their knowledge base. And part of MCRA's mission is really to educate not just physicians, but the general public and legislators. And Carrie, what would you say from the standpoint of legislative advocacy we'd like to see in 5 years?
We'd like to see, again, standards across the country. I mean, it's so interesting that a patient that will be certified and have a medical card, let's say in Connecticut, and they go to this happened to my father-in-law, and he said, I can talk about this. He had a medical card. He went down to Florida, and he was stranded there because of COVID, and he was without his medication for 3 months. He was unable to take his card into a Florida dispensary because there's no reciprocity between the states. And it's just so interesting that depending on the state that you're in will depend on what type of medicine that might be available. And so to kind of standardize it across the country, harmonize, again, good manufacturing practices, quality, potency, expand medical cannabis research. I think we are just really on the cusp of this incredible explosion of policy as it relates to cannabis, especially, with the new Biden administration. I think that there definitely is an appetite to address some of the issues that have kind of stymied research over, the last decade or so.
And one thing that I'll add, Nicholas, is that I think right now there's a little bit of a feeling of a fear of missing out on the part of many states that have not created programs that are recreational, because the way that this product is taxed is so variable in different parts of the country that some states have taxed it upwards of 70+%. So they're balancing budgets or creating revenue for infrastructure and what have you. And so I think sometimes there might be a misalignment of priorities, and I don't want to see medical cannabis be politicized in a way or used in a way that is not necessarily safe solely for economic benefit for infrastructure at a state or a federal level.
And I would also add, though, many states actually carve out medical cannabis from that taxation structure. So again, I keep going back to Illinois because we've just had this happen. So medical cannabis patients are not taxed on their products. So pretty much the same product, a recreational user will go in and buy it, and they'll get a 30% tax slapped on it. So there are some protections for medical cannabis patients, but again, that's not uniform across the country.
So just to wrap things up, the conference takes place.
It's March 13th. It's a virtual event. We'd love to have you. You talked about education and the importance of education. I think our conference is a great start. We have an amazing lineup of really true thought leaders in the cannabis space. And so we would love to have you there. There'll be a link the end of this podcast. And so anyone that's interested in learning more, please click the link and join us on the 13th.
Thank you so much for joining me and for giving this incredible primer around medical cannabis and actually touching on some other cannabis uses and CBD, and more to come, I'm sure.
Thank you, Nicholas.
Thanks for having us.
Healing Together is produced by Healthenly. Our theme song is Ramble, composed and performed by Ed Morneau.